Anterior vaginal wall prolapse. Broadly, we are talking about pelvic organ prolapse, but here specifically we are talking about anterior vaginal prolapse, that is cystocele. So, cystocele is formed by laxity and descent of upper two-thirds of anterior vaginal wall. As the bladder base is closely related to this area, there is herniation of bladder through the lax anterior wall. Now moving on to the etiology part, that is classified into two, anatomical and clinical factors. In anatomical factors, these include gravitational stress, second, anterior inclination of pelvis directing the force more anteriorly, third, stress of parturition, fourth, pelvic floor weakness, fifth, inherent weakness. Secondly, clinical factors, they are again classified into two, predisposing factors and aggravating factors. So in predisposing factors, acquired and congenital. In acquired, like trauma of vaginal delivery, which cause injury to ligaments, endopelvic fascia, levator muscle, perineal body, and nerve, and damage due to repeated childbirth. Congenital can be inborn weakness of supporting structures. And in aggravating factors, these include post-menopausal atrophy, second, poor collagen tissue repair with age, third, increased intra-abdominal pressure as in chronic lung disease and constipation, fourth, occupation like weightlifting, fifth, asthenia and undernutrition, sixth, obesity, seventh, increased weight of uterus as in fibroid and myohyperplasia. So now what would be the chief complaints? So in cystocele, there is a bulge of very degree of anterior vaginal wall which increases when the patient is asked to strain. This may be seen on inspection. One may have to separate labia and depress posterior vaginal wall with fingers by using sim speculum, placing the patient in the lateral position. Mucosa over the bulge has got transverse rugosity. Bulge has got impulse on cuffing with diffuse margins and is reducible. Now, sometimes cystocele can be confused with the Gartner's cyst. So, for the differentiation of both, there are various points. Number 1. Gartner's cyst is situated anteriorly or anterolaterally and of variable size. But cystocele is always located in the anterior vaginal wall. Second, rugosity on overlying vaginal mucosa are lost in Gartner's cyst, but as I stated earlier, rugosity are present on the cystocele. Third one is vaginal mucosa over it become tense and shiny. In cystocele, vaginal mucosa is normal. Margins are well defined in Gartner's cyst, but in cystocele margins are diffuse. Another point is Gartner's cyst is not reducible, but cystocele is reducible. Lastly, there is no impulse on cuffing in Gartner's cyst seen, but in cystocele, impulse on cuffing is seen. Now, moving on to the management part, Management distributed in 3 classification: preventive, conservative and surgical. So in preventive measure, adequate antenatal and intranatal care should be taken. Adequate postnatal care should also be taken, and general measures to avoid strenuous activities, chronic cough, constipation and heavy weight lifting. Also to avoid future pregnancy too soon and too many by contraceptive practice. Second, in conservative methods, we can guide for pelvic floor exercises that are also known as Kegel exercises to strengthen the pelvic floor muscles. Another, pessary treatment. Third is surgical management. Surgical management include, so now we are only talking about cyst-toe-seel, that means the anterior upper 2/3 of the vaginal wall. So for cyst-toe-seel, surgical management is anterior colporrhaphy, or we can also do pelvic floor repair if cyst-toe-seel is combined with rectocele and paravaginal defect. Thank you.